All right. Well, I'm going to get us going. So good morning, everyone. Welcome, bienvenidos. For those of you who want to continue in English, please stay put. Las personas que desean escuchar la versión en español, por favor, elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias. So good morning to all of our live attendees today. We are so thrilled that you're here to engage in this exciting webinar called Trans Affirmative Care in Integrated Behavioral Health. I'm Dr. Tiffany O'Shaughnessy, and I'm one of the hosts of our webinar today. I use the pronouns she, her, and I'm a white cisgender woman in my early 40s with an undercut buzzed hair on my left side and chin-length reddish brown hair on my right side. I'm wearing a black top, and my background is a mountain tapestry scene. I'm a faculty member and the MFT program coordinator in the Department of Counseling here at San Francisco State. And I'm one of the co-investigators for this project. I'm working alongside the project's primary investigator, Dr. Julie Conister, who's the coordinator of our clinical mental health counseling program, and my co-investigator, Dr. Molly Streeter, who's the coordinator of our school counseling program. I'd also like to thank our graduate assistants, Lennon Fanning and Sarah Guerrero, who are working hard to stay on top of technical issues and chat boxes and things today. I'd like to acknowledge that SF State's campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. We further acknowledge that we work on the ancestral lands and waters of many other indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We're committed to ensuring that this webinar is accessible to our audiences. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments, feedback, and support. This is our first webinar of the year, sponsored by our Equity and Justice Focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. A couple of additional things before we begin. If you're one of our HRSA stipend recipients or are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. As a reminder, this is a live recorded Zoom webinar, and therefore the audience isn't visible and the audience can't turn on their video or audio. The chat function is available though for comments or sharing of resources, supportive emojis, just engaging with the content. If you want to ask our presenter a specific question, you can go ahead and post that in the Q&A function, and that Q&A will occur during the last 10 to 15 minutes of the webinar. So please post your questions as they come up, and then we'll answer them as I'll get to all that we can at the end of the webinar. If we can't get to all the questions, we'll share Dr. Reed's contact info, and so hopefully you could follow up with him afterwards. And so with that, it's with great pleasure today that I introduce our presenter today, Dr. Oak Reed. Dr. Reed received his doctorate in clinical psychology from the University of Montana after completing his residency at the Clement J. Zablocki VA Medical Center in Milwaukee, Wisconsin, with an emphasis in health psychology. Over the years, he's worked across diverse clinical settings, including outpatient mental health and university-based primary care clinics, community and university-based medical centers, and a variety of clinics within the Veterans Health Administration. Oak's primary research interests include analyzing motivations and impacts of anti-transgender prejudices and investigating barriers to care seeking among transgender individuals. Most recently, his dissertation investigated the impact of a transgender affirmative care training had on healthcare providers' competence and confidence in delivering adequate care to gender minority individuals. In addition, he's published both empirical and theoretical articles, book chapters, and book reviews on sexual and gender minority topics. Oak has been invited to lecture on his research findings at universities and healthcare settings to both national and international audiences, in addition to serving on several diversity work groups. Currently, he is a full-time licensed clinician and regional director at Active and Connected Family Therapy, where he provides individual therapy for sexual and gender diverse individuals, veterans, and individuals with complex medical conditions, in addition to facilitating interdisciplinary case consultations and providing psychoeducation to colleagues and community members. I personally have been so fortunate to know the brilliant Dr. Reed since he was an undergraduate, and I'm so excited to continue learning from him today. So thank you again for joining us today. Oak, I'm going to hand it over to you.
Wonderful. Thank you so much. And it's It's an honor and hopefully setting a good tone being the first webinar. I didn't realize it was the first one. So hopefully we can kick it off really well. What I will say is that having provided this training and iterations of it now for several years, I find that there's just so much information to pack into an hour. So I'll do my absolute best to get through the material in a meaningful way and save room for questions. But like what was mentioned, there's always room for follow-up questions via email, and I'm always here to answer anything that I can. So without further ado, my name is Dr. Oak Reed. I use he, him pronouns, and let's jump right in. So I think one of the most important questions to start with is like, what do we even mean by like affirmative care and trans affirmative care in particular? And I think even more broadly, gender affirmative care. Well, I think just to set the tone, the idea of being an affirmative provider is being educated on what those identities mean, certainly being aware of barriers to care historically and currently. Being conscientious of creating a very welcoming, warm, and safe environment is going to be one of the key things, and that's a huge focus of this training. And then knowing that sometimes we as healthcare providers are the ones that are being disclosed information to, we are the ones who are facilitating connections. We in turn become advocates for our clients, and we're the ones who are advocating for excellent physical, mental health services and the collaboration between them, so that that collaboration and interdisciplinary approach can focus on achieving that holistic and wraparound well care for gender minority individuals. So this is just a general outline, kind of a just idea of what we're going to go over, kind of starting with some of the background information, statistics, history, and current area of where we're at in regards to mental health and physical health care for gender minority folks. And then shifting into practical strategies that you can implement today, which is what I love. They're very tangible, practical skills that you can implement today in your practice in order to be that advocate and provide affirmative care. And I'll leave with some just general recommendations, resources that you can review. I'll try to keep my eye on Q&A as we go on, but we'll certainly leave some time at the end. And then here's your learning objectives, just to take kind of the takeaway points from our training today. And before I jump into one of the things I want to share that I'm incredibly excited, and you'll probably hear me talk about throughout, is that in graduate school, I also was a BWET HRSA grant in trainee. And so I worked in integrated healthcare settings under a grant like that is funding this webinar right now. And so being on the ground, working in integrated care settings was the foundation of my training. And it has informed how I approach care now, how I think about intersectionalities of different identities, working with people of all diverse backgrounds, including sexual and gender minority folks. So it's just really humbling and exciting to be here on the presenter chair now. So in order to, I think, work with anyone, we need to kind of understand the important terminology related to that population. So this might be a review for some folks, but I find that it's still important to always start here, because this isn't something that's always explicitly talked about in grad school, in healthcare training settings, and so on. So I like to just kind of separate these three terms because they're used often very interchangeably, and we need to ensure that we're using them appropriately and separating them out. So here's how I think about these three terms on the screen. I think about sex being more biologically driven, things that are affiliated with anatomy, so internal, external genitalia, our chromosomal compositions, the hormone balances. And we historically have categorized sex to be based on the binary. We think of male and female. However, sex is even more complex than just that. There are all different iterations of internal and external genitalia, different chromosomal compositions outside of XX, XY. There are kind of different balances of hormones than just purely testosterone, purely estrogen. So this is a term in and of itself that we need to have a pause and thinking about what is informing a person's anatomy. How does their anatomy look like? And that's going to be important as healthcare providers, as mental health care providers in particular, as we're collaborating with our physician friends in learning about the sex that might have been assigned at birth, so that we have good terminology, ways to have informed conversations and so on about that person's physicality. Now, how gender differs is that gender is based on how we describe ourselves. It's our identity. And so it's only something that an individual can describe for themselves, not something that we or society can describe for them. So gender is quite a vast term or a construct in the sense that there are so many different identities and terms that an individual might use for themselves. So they might use terms like male, female, they might use terms like bigender, genderqueer, gender expressive, and so on and so forth. The lexicon around gender has grown over time as individuals self-identify and share that. And so we need to not only have information and knowledge about the sex that was assigned at birth or what their current anatomy is, but also gender identification, how they describe themselves. And then sexuality is different, and I have a different slide that breaks this down a little bit further, but sexuality is vastly different than sex and gender, because that's moreover talking about our attractions, behaviors, and identifications, completely separate from our sex or gender. So we need to make sure that we're not using these terms interchangeably. We are indeed recognizing that sex does not necessarily dictate gender, which gender does not dictate sexuality, and every iteration in between. We need to separate them out and respect that they are separate entities. Now, this term transgender, and like I said when we started, this training historically has talked about transgender affirmative care based on the history that the word transgender was kind of recognized as a broad term that described folks within a gender diverse spectrum. However, as things have changed, the word transgender is now kind of more overseen as one gender identity. Sometimes it captures multiple, and sometimes it might just be a standalone identity of itself. So I think about this term a lot and what it means and the history around it. But when I talk about identifying as transgender very broadly and as simple terms as I can put it, it simply is just describing someone whose sex that was assigned at birth does not match their gender identification, or someone's sex who was assigned at birth or current sex presentation might not match with their gender identification. So that's a very simplistic way to put it, but it's just describing folks who have this difference in their sex, their anatomy, and their gender, their identification. Now, earlier, we heard the term cisgender. Dr. O'Shaughnessy identified herself as a cisgender woman. So I think about that term too, as what does that mean? And when we hear that in conversation, how do we understand and describe that and use that when we're talking about different clients we're working with too? Well, just as simply put as possible, again, when we talk about the word cisgender, the term cisgender, it's when someone's sex assigned at birth or perhaps their current sex presentation matches with their gender identification. And so that's just kind of a parallel term that we've seen in the literature and our just dialogue in public about describing what a cisgender identity means. I mentioned sexual orientation being more kind of complex and multifaceted than just a one identity, because I think it's more complex than just that. So when I think about sexual orientation, I think of it being comprised of our identification or the labels that we're using for ourselves. So that might be gay, lesbian, bisexual, asexual, queer, so on and so forth. Those are the labels that someone might use for themselves. Whereas behavior are the sexual behaviors that we engage in with partners or the types of things that we engage in. And then attraction are just the things and qualities, characteristics, and so on that we're attracted to. And so attraction of hair, not hair, color of a person's skin, non-color, different components of a person are things that we might describe as things that we're attracted to. Behaviors, or the attraction, does not dictate the behaviors that we're engaged in, and the behaviors does not dictate the identity. These all are kind of separate components that comprise a person's sexual orientation. And although this training isn't necessarily about affirmative approaches for sexually diverse individuals, I think we would be remiss to not acknowledge that folks who identify as gender diverse also certainly have their own unique sexual orientation. So it's the overall picture of a person that we're thinking of when we're being affirmative. And if it's relevant for us in our care towards that person, or the collaborative care that we're working with our physician counterparts, school counterparts, etc., we might want to know things about a person, i.e. their sexual orientation or their gender identity, to ensure that we are being the most affirmative we can. And so, okay, we start with this 101 of what are these terms? What are kind of like the basic foundations of them? For some, like I said, might be review. For some, it might hopefully just be a good refresher or just ways to think about it. And my way of thinking about it might not be the only standalone way to think about it. And I'm always open for feedback or different ideas, because as identities grow and develop, the way that an individual conceptualizes might change. So I also want to acknowledge that I am one perspective and one person, and I likely get things wrong at times. I might misspeak. I might not know everything, certainly. So I think being an affirmative provider is also recognizing that things change over time, and to be open and vulnerable to feedback. And so through the years that I've provided this training, I have been provided feedback on different language I've used or so on. So I think being an affirmative provider is certainly being open to that. And so I want to own that I might say things that might be different than what other people believe or conceptualize themselves. And let me know, because that makes me a better provider. But once we kind of think about the basic terms, people say, okay, Oak, like I'm down with that. I get that. Like I'm wrapping my head around that. But like, what is the age range? When am I going to work with these individuals? And so I think about identity development. When does this develop? And the developmental literature has said that the onset of gender identity is typically around the age of 3 to 4 years old, if not earlier. And that's not specifically just talking about gender diverse individuals. That's just kind of saying gender identity in and of itself onsets around 3 to 4 years old. So when the developmental literature is making statements about that, they're commenting on the wholeness of our gender identity, even if early research didn't recognize or talk about gender diverse identities. They were in turn kind of recognizing that our identity development happens pretty early, regardless of if it's within the binary or not. So I think that that's important historical data to pay attention to, and something that in more modern data and research, we've reinforced this, that identity onset and identity realization is quite early. So what that means to me is that we can work with people that have diverse presentations at any age, at any setting we're working with, and it really communicates that we have to have open and active listening, both ourselves as clinicians and ways to kind of like share this language with other school providers, healthcare providers, parents, etc. So then I'm asked this question of if it can be essentially the entire lifespan of a person that I could be working with in regards to talking about these constructs. Well, how prevalent is it? What is the likelihood that I will work with an individual that presents this way? And so this first statistic, the 1 to 1.3 million Americans, is from a meta-analysis published in 2017 by the American Journal of Public Health, which I think is a robust number, just saying, yeah, there's a lot of individuals out there that identify this way. So therefore, there's a high likelihood that we're going to, if not have already, worked with someone that identifies as gender diverse. This other statistic is looking at more child or adolescent identified individuals in America, 300,000. And that was from looking at data from census and some research that had been done in school systems. Now, when I look at these statistics, I think of them being a gross underestimate of the likely actual prevalence. And the reason being, and I point this out as healthcare providers and likely as researchers too, when we think about our methodology, historically and even currently, we don't always ask about sex, gender identification, current presentation of identities, importance, salience of identities, and so on. We sometimes have historically conflated those. We've used surveys where we say gender/sex, or we only have one or the other. And so not only have surveys, research not fully robustly measured this idea, but we might have created unsafe situations for people to like be a little curious of like, do they even know what this means? Do I want to disclose of this? If research says that they're confidential, they're anonymous, there still is this historical fear of being of this identity and them disclosing of this being used against them or being putting them in a vulnerable place. So either surveys just quite frankly don't ask about it, or individuals might be a little hesitant, reluctant to disclose of this. And so that's why I think these statistics are largely a gross underestimate, which if we go with that idea, then what we can say is there's a whole lot of individuals that can benefit from an affirmative approach to care that, you know, really need some of that advocacy and sensitive care from healthcare providers. I've intentionally had some of these photos on the screen because I think when we're talking, sometimes we get distracted and we're looking at cute photos of babies and so on. But I did this intentionally because I think sometimes when we're looking at photos, we're looking at videos of people, we're, you know, listening to speakers, it's natural inclination of us as humans to start to categorize people, right? We look for cues that are associated with certain characteristics or labels or identities, and we categorize them because that makes us sometimes feel comfortable if we feel like we know something and we can categorize folks. When it comes to gender, we often categorize people into the binary of male or female. That's just sometimes a natural propensity of us. I think we as a modern society have done a really good job not doing that, but I think we all always have room to grow. So you might have been looking at cues of like the blue pool, like maybe that's a baby boy because blue has been associated with men and manliness. I don't know. The other one has a shopping cart, and you know, shopping historically was more of a feminine or, you know, a female associated practice. And so it's just these little stereotypes that we don't even think we're aware of that show up to categorize people. And if there's one takeaway from this training that I leave you with, is to slow that process down. Allow people to inform their identity to you as they feel comfortable, as it seems appropriate and right, and as it's naturally facilitated in a conversation. And so to leave you with an answer to this question is that both of these photos are pictures of me when I was a baby, but you also know nothing about me, right? Other than the things that I've shared about me with you. And so again, slow that process down, right? So this other picture here is just kind of a general description of what a lot of people talk about when they feel as though they have that mismatch of their sex that was assigned at birth and their current gender identification, that they have this identity that's within them, but they maybe don't always know how to express it, explain it, and they feel pressured. And there's this concept of gender dysphoria, whereas gender dysphoria is this idea, and it's what the DSM categorizes this diagnostic category as, but gender dysphoria is this idea where if this distress around the sex that was assigned at birth, or kind of influences or pressures to identify and align behaviors with their sex assigned at birth and other kind of stereotypical things, if that causes distress and it's something that it feels consistent, a person is persistent and they're insistent that something isn't right, and that continues into puberty, throughout puberty, well, it's unlikely to go away. Because a lot of folks say this might be a phase, it's something they're going through. Well, this is where that active listening plays a huge role, is that we really want to hear this out very early on and start to kind of think about things that we can do as healthcare providers to help facilitate a healthy identity development, knowing that when it's consistent, they're persistent, it really is unlikely to go away. So we need to think about what we can do. And by go away, I don't mean just like go away. I mean, it's unlikely that those thoughts or those feelings are going to resolve just by waiting it out. You know, it's likely that that's going to carry through with them. And we want to alleviate that distress as early as possible so that they can lead a healthy and happy life. Okay, so I think one of the steps of being an affirmative provider is understanding the current and historical barriers to care that this population has faced in order to remove them, reduce them. This resource I love. So the Movement Advancement Project is a phenomenal resource that what I love, and especially when we're thinking through integrated behavioral health, we're often in places that are underserved, that are more rural, and so on. And what I think about this resource and what it provides is a snapshot kind of at a big picture in the US in this case of how we're doing as a country. But what I love about it is it's often updated, and you can click in state by state, often region by region, city by city, and they have really good data to look at in regards to, in the area that I'm practicing, how are we doing? What are some of the laws, regulations, pushback, support, and anything in between that's going on so that you can be informed of what your clients are up against in your particular place of practice. And so I briefly saw in the chat, people are tuning in from all over the place. I loved that. I'm tuning in from Virginia right now today. So we all maybe have different barriers that we're facing, just depending on where we're practicing. So this is a really cool, informative resource to look into. And one of the kind of devastating things about it compared to previous years in this presentation is historically, I've been able to say, I would show kind of snapshots year to year and say, look, we're actually making progress, and the red has gone to more green or at least lighter colored. And unfortunately, the opposite has been occurring recently. So for anyone who's been following a lot of different developments in regards to laws and policies that protect trans or gender diverse people, they have largely decreased. And there's been a lot of negative news and laws out there. And so again, with highly trained, highly educated voices, we are the people that can advocate, because we are the people who can cite the mental health distress and, in tandem, kind of physical, sometimes distress that can be caused by not having safe outlets, not having affirmative approaches to facilitating identity development, and so on. So just for comparative purposes, this is where we're at. Earlier this year is when I took this snapshot, and here's where we were at about a year prior to that. So unfortunately, things haven't been moving in the direction that we certainly would want it to, but that doesn't mean that we don't have the power to make any differences. And so I think that this goes client by client, city by city, state by state, and so on, of where we can use our voices to advocate for change. Another really phenomenal resource, and I am just holding my breath, waiting out for the most recent iteration, but the National Transgender Discrimination Survey is the largest survey that has been conducted domestically, looking at what are the experiences of transgender and gender diverse individuals, and really doing a wonderful job looking at kind of all different domains of life, from disparities in health and healthcare, which I'm here to talk about, but they look at disparities in school systems, in religious places, in family systems, and anything else in between that you can think of. They've done a wonderful job collecting data, generating these reports that are so digestible. You do not need to be a highly educated individual in order to like appreciate and glean information from these, which I really love. Because as you all probably know, being in your programs and your place of practice, sometimes research can get incredibly jargony. And then people put it down. They're like, well, I don't want to read this anymore. This is tough. So I love these surveys because they use very straightforward language. It's very clear to understand what they're talking about. And most importantly, they interject voices from the community. So they have a lot of anecdotes from community members interspersed throughout these surveys. So this one particularly was published in 2015. We're just waiting for the one to get published that was data collected in 2021, 2022. Like most things, COVID delayed the kind of progress on that. But one kind of statistical thing I want to point out is that the first iteration of this was in 2009, and there was about 8,000 respondents. 2015, you see here, there's about 28,000 respondents. They're anticipating significantly more, or what they know of, they had more in the 2021, 2022 response, which at least gives us a glimmer of hope. And I wanted to contrast that to this place of kind of like despair that I just pointed out with the map looking not as good, is that the voices and those within the community are speaking out. They're sharing their story. They're talking about the celebrations and the setbacks so that we as healthcare providers have more and more to understand where we need to intervene, what we need to do to continually reinforce the things that are going well, and also pursue change for the things that are not going so well. So I'm going to kind of touch on each of these briefly to kind of talk about what this survey is going on and what those barriers are too. One case study that I want to interject before going in, because I think case studies really highlight what's going on, and it's just a fun place to share things that I've learned from. So for this case study, this was talking about a 9-year-old individual that was assigned male at birth. They were in elementary school at the time that they sought services from me. This person also identified as, in their words, Hispanic, and they wanted to explore their gender identity. And this was the 9-year-old's goal: explore their gender identity as they predominantly identified as female. However, the parents did not have that as a similar goal. Their goal in therapy was to, quote, remove that child's thoughts. And so why I highlight this case is because on one hand, it is so beautiful and wonderful when I have families come in to see me, or adults or whoever it might be, that have wonderful support systems, that there's this mutual goal of just supporting identity development. But not always are we getting those cases. Sometimes there can be discrepancies. There can be sources of uncertainty, of unknowns, or just kind of very blunt, we need to get rid of this thinking. And why I point this out is that although APA has made, and many other mental health entities have made strong statements very clear in their lack of support of conversion therapy, and the 2015-29 surveys talk about the distress that conversion therapy had caused on transgender and gender diverse individuals, that it is still legal in some states to practice that. And so we want to be aware that that can be something that people are asking us to practice. And we also want to keep in mind when we are collaborating with other individuals that we ensure we have appropriate referral sources, that when we're referring, it's for affirmative, safe approaches, not things that are going to cause potentially more damage. And that our physician friends, our school friends, our other collaborators know that we are a safe source of affirmative care. And so this was a challenge of me to gently try to provide education around the fact that removing that child's thoughts might not actually be the most safe, healthy, and so on. Why I put that a CPS report was required was not because of them asking me to remove the child's thoughts. This was actually related to other things that the child had disclosed of during our session about harm that they had encountered from their parents. And so one of the things that we have to think about as healthcare providers is our mandated reporter status and our duty to protect our clients. And keeping that in mind, that a lot of times, a lot of folks who identify as gender diverse are at a higher risk of discrimination, prejudice, harm from friends, family members, other folks in their life. So we want to kind of keep this in our awareness and think about those reports that we are making. Just be very conscientious of them. Of course, we're mandated reporters if we're mandated reporters, but know that when you contact CPS, there always is that option to ask in a de-identified way, is this reportable, and allow them to kind of help too. So I just put that in there to think about just different layers that come into the room, because it's not always certainly straightforward. So when I think about routine and transition-related health care and coverage, this can be a barrier to care, especially when we're working in rural places. Some of you might be working in FQHCs. I worked in one of those in Montana. So we want to think about where their health insurance is coming from. Do they even have access to it? What is their source? Is it private, public? What is their coverage? Is there specific clauses in the healthcare that says it explicitly covers any gender-related care or explicitly doesn't? Because sometimes there are very strong clauses that say we do not cover, and sometimes it's so blunt as like sex reassignment surgery. Like there's still very, very outdated language. Anyone who's worked with health insurance knows how slow that process is in and of itself, but how sometimes outdated and kind of ancient it feels. So we want to kind of just be aware and think about this. Where do they have health insurance? Where is it coming? And is it something that actually is affirmative in and of itself? Thinking about routine care, this is your just annual visit. This is head cold. This is a PAP. This is a prostate check. This, those things. Think about their outness. Are they out to their provider? Is that something that they have the option, the safety to be out? Think about providers' knowledge or openness to talk to individuals that identify as diverse. Think about wellness exams. Are our physician friends equipped and educated on what it means to do a pap smear on someone who identifies as a trans man per se? Or is that going to be a really uncomfortable and unsafe situation? So we want to just be thinking about all this as mental health providers so that we can process it with our clients, and we can kind of brainstorm ways for them to either, share information with their providers. We can be the advocates of getting a release of information, talking with those providers, talking with school counselors, talking with, anyone else that might merit a collaboration with, so that we can decrease these barriers. And then thinking about transition-related care, this is something that's very much so on my mind with the ever-evolving landscape of the US in regards to access to hormone therapy, hormone blockers, surgery, and so on. But we want to think about other things like therapy. We, in and of ourselves, as mental health providers, can sometimes be a barrier to care, because historically we were seen as being kind of quote unquote gatekeepers, in the sense that folks had to come to us, and still do in many states, in many places, have to come to us to get a letter written by us. And sometimes if you didn't have a PhD, someone had to either co-sign it with a PhD, or it had to be referred to another person for a second opinion with a PhD or a psychiatrist. And all of these layers that existed, that we could kind of be that gatekeeper of either yes or no. I think this person kind of quote unquote fits criteria to get therapy, hormone therapy, surgery. And we need to check ourselves. Is that our place? How can we be more of a facilitator in a healthy way rather than a barrier or a gatekeeper? And so we want to think about these barriers, because the outcome is that these individuals are just denied care because of their insurance, because of providers not being familiar or knowing what to do, or people being gatekeepers. They might be refused care, outright refused care. I myself, in full disclosure, as a trans-identified male, have been refused care. I've been in situations where someone has said, I don't think you belong here, so you need to leave. When you're in like incredibly vulnerable situations, or they might postpone their own care because they're like, I am sick of all of this discrimination, this mental preparation that I have to do to like just go get, a flu shot. I'm just not going to. And the outcome is that there's a lot of then health disparities that are created. I'm not going to read these to you, and I'm happy to share my slide deck for anyone to review after, because I know that we're going through material relatively quickly, but I wanted to highlight that there are these quotes that are really wonderful throughout the surveys that I was referring to. both ones that kind of highlight the heaviness in the voices and the frustration and the areas of barriers, but also some that really highlight the alleviation, the hopefulness and the positivity that affirmative care can be. So I encourage you to go through and read some of those quotes because they're really wonderful to see the balance. Okay, so then overall health and psychological distress. I think of the quality of care, continuity of care, and appropriate self-care education, because often if people are being denied care, refused care, their quality of care diminishes, their continuity of care now is bouncing from place to place, which we know just at baseline already affects someone's wellness, both physically and mentally. And then if they're not having that quality and continuity of care, then they're not getting appropriate self-care education because they're not having the opportunity to learn healthy coping mechanisms, healthy safe sex practices, or other kind of health hygiene. And then from a psychological distress lens, think about the dysphoria. If that person at 3 years old is talking about some dysphoria and that's dismissed or not really readily addressed or supported, that grows and that creates stress, anxiety, and hypervigilance in any kind of area of their life. That might lead to depression because there's hopelessness and heaviness around, nothing's ever going to change for me. And there is, quite frankly, a lot of fear of safety in many situations. And so the outcome is that because of these barriers, we see increased rates of HIV, AIDS, other STDs, substance use as an unhealthy coping mechanism, more severe psychological distress because of the lack of ability to talk through these things and ways to process it. And then we, of course, see more instances of self-harm, suicidal ideation, suicide attempts, and deaths by suicide within this community. And the statistics around suicidal attempts and completions is just outright unacceptable, right? Because it's often over 50% or more of individuals within this community have had thoughts, had attempts at some point in their life. And that's a statistic that we absolutely can change by being affirmative and creating these collaborations with our colleagues. Because what I see, what happens is that there's this cyclical cycle that occurs where there's both this historical and current existence of prejudice and discrimination towards this community. And what that fosters is avoidance. Like I was saying, avoidance of getting necessary health care, avoidance of talking to mental health providers, of having safe outlets with family, friends, etc. And when we have avoidance, we then see an increase in health disparities because we're not learning about safe health hygiene, healthy coping mechanisms. We're relying on unhealthy, yet maybe accessible coping mechanisms like drugs, alcohol, self-harm, and so on. But when we see reports on these health disparities with this community increase that doesn't provide this context, that fuels more prejudice and discrimination. Because what happens is other people might perceive this community as having mental health disorders, as having just unrestricted substance use problems and all of these other prejudices and stereotypes that exist, but it's sometimes not contained or not informed by all of this other stuff going on that we know about, the disparities, the barriers to care, and so on. So what we need to do is just simply break this cycle. It's not as simple as that, but I think there are some really simple, direct approaches that we can use to break this down and at least reduce the rapidness and viciousness of this cycle. And I certainly believe that anyone who's joining here today, no matter who you are, where you're coming from, what your field of study is, that you certainly do have the ability to single-handedly change the life of a transgender individual or someone who identifies within the gender diverse spectrum just by being affirmative, being here, listening to this, and integrating some of these approaches into your aspect of care. So the question is, how do we overcome these barriers then and create a welcoming environment? Well, that's what the kind of idea is of thinking about these practical steps. I'm going to kind of move forward and think about any questions. But what I want to say is this is a quote that I have left from the get-go, from the first time I ever made this presentation, because Dr. Joey Banks, who at one time was just a family medicine physician in Montana, she moved on to be the chief medical director of Planned Parenthood of Montana. Love her. She's a wonderful colleague. She also practiced rural medicine in Africa, and just her approach to care was just so well-rounded. I loved it. And she was just a matter-of-fact kind of gal. And she said, it's not rocket science. Anyone who's in the healthcare field knows, about 99 to 100% of what they need to know to care for this population. And I couldn't agree anymore. Sometimes people say, like, I'm not a quote expert on this. I don't know what to do. I'm going to refer. And you don't have to. You don't have to be a quote expert, because we all have the tools we need in order to be affirmative providers. We just need to find that confidence and find those practical skills of how to do it. So here's how. Another case study, and to be fully transparent, this case study is actually me. This was something that I experienced when I was 25 years old as a grad student. At the time, I was completely post-op, meaning I had had all of my surgeries. I had been on testosterone, all the surgeries that I desired, let me correct myself. And I had been on testosterone for years, and I'd been living male for a majority of my life. Yet, I still experienced pushback. Medical providers, when I moved states, wouldn't continue my prescription of testosterone because I needed a new letter. I needed an updated letter. I needed, they were using insensitive language, even though I appear masculine, and that's something that I feel comfortable with, because if you could see me, I have a button-down shirt, I'm balding, I've got a beard, and that's fine with me. That's how I feel comfortable. But they would often learn that history of my identity and make my pronouns wrong, or use wrong pronouns for me, and it just made no sense to me. And I have been plugged into therapy ever since I can remember, because it was a place for me to process my frustration, anger, hopelessness sometimes with the system. And why I share that, and why I want to share my own personal story, is that this is something that often is ongoing throughout an individual's life. And so it's not a discrete period in time where we can, wipe our hands clean and say, great, that person got the services they need. This is something that can show up with clients of yours that you might not know this history of theirs. Because quite frankly, not always do I share this in my trainings. Not always do I share this with every medical provider I interact with, because sometimes, quite frankly, it's not their business, and it's not why I'm going there, because COVID test isn't affected by my gender identity. So they don't need to know, right? But sometimes it shows up. And so just as mental health providers, we want to be astute and aware that this can show up at anyone's time in their life, regardless of where they're at through their transition process and so on. So these individual strategies that we can implement, we don't want to assume. And that's where I initially started that picture exercise, because sometimes we assume, we want to box people. And the cheesy phrase that probably, one of your grandparents or so on said to you is like, don't assume, it makes an ass out of you and me. And it kind of does, right? So we want to just drop that assumption. And there's such simple ways we can do that, because I've noticed it very drastically being from the north. So I'm from Michigan originally, now being in like a southern state, that the sirs, ma'ams are just so ingrained in this area. And just think about that. Like, how may I help you, sir, has an assumption, has a categorization, a binary box to it. And if we just drop that, which I know I'm like challenging a whole history of a culture, maybe at a region of the US or so on. But if we think about just kind of checking in with our own idiosyncrasies and things that we do, just dropping sometimes some assumptive language can go a long way. So how may I help you, sir, is very different than how may I help you. And on the flip side, and I've caught myself, we don't want to also be on the overtly like aggressively affirmative side, if that's if that makes any sense. So we don't also want to assume that someone would benefit from gender affirmative care or so on because we like think they might be gender diverse, or we think this about them. We also don't want to assume that. So we don't want to be like, hey, yeah, great, join us, we're an LGBT friendly clinic or something, just because we think that that's what they need. Thinking about like, we're a welcome clinic for any and all. Like, we meet people where they're at. We meet needs, and we advocate for them in any way, shape, or form we can. So we want to just kind of like not be on either of the polars. We don't want to assume how a person describes themselves or their partners. So again, simple things that we can do when we're writing notes, when we're communicating to our colleagues, when we're talking to administrators or care coordinators or whoever is in our wheelhouse of colleagues. Rather than like, Sarah's here for her appointment, we can say things like, your patient is ready to be seen, the student needs to have, talk to you, different things like that, that kind of drop some of those assumptive languages, or how they describe themselves. Dropping kind of assumptions around partnership. Do you have a husband? Do you have a wife? Tell me about your partnerships. Tell me about relationships, things like that. And we also don't want to assume background information, because historically we know that a lot of individuals who identify as gender diverse have been kicked out of their family systems, not allowed in certain settings, whether it's religious, school, athletic, different things of that nature. So we don't want to assume any background information. So something like, rather than mothers and fathers' names, who helped raise you, or tell me about your upbringing. Tell me about, who you feel safe talking to. And then on the other end, we also don't want to say things like, because I've been told this enough times and it just drives me bonkers, but you would have been just such a cute little girl. That's an assumption. That's thinking and commenting on someone's background information that likely might not be true for them or might be really jarring. So we want to kind of be protective against not going to that side of things. Body language, back to basic 101. We want to think about how our body is in the space with someone, because they're probably already experiencing some body dysphoria in some way, shape, or form. So we don't want to be scanning them for cues and looking at their body in awkward ways. We want to have open, expressive language, just thinking about that on, video screens. We want to just kind of try to maintain helpful eye contact, just be open and present, and just kind of really thinking back to that 101. We don't want to close off ourselves, crossing our arms, looking confused or uncomfortable. We want to just maintain that open presence. Addressing individuals, we want to think about pronouns. We want to think about the fact that a person's driver's license, school records, records on an electronic health record may or may not match their birth certificate, which may or may not match how they're currently presenting to you. So we just want to be conscientious of that. And importantly, check in, kind of like intermittently, because identity is fluid. People's identities might change and as they grow into themselves and are exploring different things. So we don't want to have just like one discrete moment in time when we're asking or thinking about these. Kind of keep it as an ongoing thought and conversation, and just check in with individuals. And ways that we can ask is to, oops, sorry. My slide wasn't loading there. Okay, yeah, if we don't know, we can ask certain things like, what name would you like me to use? What are your pronouns? We could demonstrate them with having pronouns on pins, on our name tags, so that we're kind of expressing things to them so that they maybe feel more comfortable to us. If a person's name doesn't match insurance on their chart or things in school records or anywhere else, just asking really gentle questions. Could your name or chart or records be under a different name? What does your insurance have you listed as? Just being really nonchalant about it. Not making a big deal is really important. And if you make a mistake, don't sweat it. Just take a note, affirm the patient the next time. Because what can happen is if you make a big deal about it, then you're almost asking them to comfort you, saying, no, it's not a big deal. And then that might put them in a weird position where they have to like constantly make people feel better for making them feel uncomfortable. And it's just like a weird reciprocal thing that can go on. So just like take a note, affirm the person the next time. These are just kind of ways to think about and find this language for yourself of what makes sense in like your documentation. Is less better than more, or is more descriptors going to be really important, especially if there's a lot of players in an entity where it can be really important for you to communicate certain things to them. I'm actually going to skip over this case study really quick because I'm recognizing I get so excited about these and just recognizing time. But I want to briefly mention this is just generally speaking, if you are working with medical providers, talk to them about how are they talking to their patients about anatomy. And although it can be intimidating to talk to physicians, nurse practitioners, PAs, because we feel sometimes a historical power differential, just kind of like gently saying like, hey, how are you talking to your patients? Like, do you talk about current anatomy or an organ inventory, which was the most recent EHR I worked under? They had an organ inventory, which I loved because that was just more over notating like what is a person's current organs and what have been potentially removed. I felt like it was a very affirmative way to describe it. Just ask them like, are they asking these questions because they're necessary? Are they asking these questions in a safe, affirming way? Because that same provider I referred to earlier, Dr. Joey Banks, said, it's not going to change how I do a pap smear if I refer to this person's anatomical vagina as a penis. And just saying like, I'm going to touch your penis now because maybe that's how that person uses it. She's like, I can still do a pap while affirm them, even though no medical school book will tell me to use that language. She said, I can still use that because that's what's going to help that patient. So encourage your physician friends to feel comfortable like breaking out of the norms of the medical literature, because research shows that the average amount of research or training that medical providers and us as mental health providers get on trans affirmative care is often 1 or less hours across their entire training. So we can be the educators sometimes. Okay, respect, curiosity, empathy certainly go a long, long way. Ask, apologize, move on, but just think about the balance between these 3 things. And lastly, and just in the nick of time, the organizational strategies. So things you can advocate for both yourself and those who you work with and where you're working with to implement. So gender neutral bathrooms. There's so many single stall bathrooms that do not need to be single stall, but they're gendered anyway, right? Like it's silly. Just because one has a urinal doesn't mean that someone can't use the toilet that's still in there. So advocate for all gender restrooms, or at the least know where they are, and in your place of work, put up maps, because that'll decrease the stress and anxiety that someone who doesn't know what bathroom they should appropriately go into to be able to find those. Continue safe zone trainings or affirmative care trainings. Advocate for organization in an electronic health record or whatever the database is you're working with of how pronouns, names, information is gathered. Check in with your non-discrimination policy, because it's important to advocate for not only the folks you're working like for the service you're providing for, but also your colleagues, right? And yourself. So look at that. Think about your environment around you. So office decor, books, magazines that just are subtle indicators that this is a safe space, flags and things like that. And then look into state-specific and city-specific resources so that you are informed of what your surrounding area looks like. So this is the homework and the takeaway, is to locate those gender-neutral bathrooms, add that decor, look at paperwork for inclusivity, think about how your documentation looks like, how your verbiage sounds like, practice normalizing asking questions, and know that the key to the health and wellness of this community is those interprofessional collaborations and creating a healthy environment. So didn't leave time for questions unless I'm here to linger if people are, but here's my email. I'll share the slide deck. But thank you so much for inviting me.
Thank you so much, Dr. Reed. That was amazing. You're getting a lot of hearts and love in the reactions right now. And if you do have, I could stay here for another 5 minutes. There is one question that came in if you want to answer that one. Does that work for you?
Yeah.
I want to respect your time as well. Okay.
No, I've got time. Absolutely.
Okay, great. So yeah, so David wrote in, and I'm wondering if that's David or Cole, might be one of our graduates. Is there an ethical way for us to work with a client like the one in the example you gave, where the client is a child and the parent's stated goal for therapy is removing the thoughts of gender nonconformity? If we don't agree with the parent's goal, but do think the child could benefit from therapy with us. So they wanted a little more on that the ethics of that.
Yeah, that's a great question. And it's a sticky situation that we can be put in, because we might know the history and statistics around it's going to be more mentally health from a mental health perspective aversive and damaging to, you know, practice any type of conversion therapy. But if the family is pushing for that, how do we balance that? Well, I think a balance of psychoeducation for the family, and sometimes it's really taking a good gauge of how open are they to hearing about this. And so how I approach things like that is saying to this family, and unfortunately this family didn't stick with me for too long because I think it was a little too much for them to take in, which was really unfortunate. But other families that have been kind of in a similar camp of like, we just think this is a phase, we're pushing back against that. I remind them that this doesn't have to happen overnight, even though that kiddo might be saying, I want this to happen overnight, perhaps. I'm ready to identify this way. I want this affirmation. That finding like a balance with the family and the child to say, well, what are things that we can do at home to feel how this feels like? Can we allow you to wear clothes that feel affirmative well at home? And maybe mom and dad aren't ready to see you do that out in public because of XYZ, and trying to have just an open dialogue. But let's see how it feels at home, because I want to create that safe space for you at home. So I try to find kind of gentle kind of ways to chunk that exposure in a way. I'll give them good resources of children's literature, like little like books that they can read that are from trans-identified authors. Like Stacy's Not a Girl is one of my favorites. What's the one? Red, a crayon story where it's like the red crayon wrapped in blue wrapping. So it's like these digestible, you know, books and pieces of exposure that they can share with their kids and learn themselves, because they're like not, you know, in your face, this is like how you should do it resources, but like things that they can gently use with their kid and kind of start to think about themselves. So it's a very gentle approach that you can take, a balance of psychoeducation while also trying to find that way to affirm the child too, of what are things that you need in this therapy space to process through. How does it feel to have this mismatch with, you know, your parents? And so it's a tough balance, but I think it's that balance of psychoeducation with the family and then finding ways that they can slowly integrate some of those changes into their life outside of the therapy room.
Awesome. All right, I do need to wrap us up because I know we've got our translators working hard in the Spanish language channel and want to make sure she gets to be respected for her time as well. So thank you again so much. It was so informative, so helpful, and so lovely to see you. Yeah, you can see all these things. You all have Dr. Reed's contact info. Go ahead and reach out if you'd like to. And thank you. You kicked off our year of webinars so beautifully. Very much appreciated.
Yeah, love it. Thank you so much.
Have a good weekend, everyone.